So we now have a pain case that is roughly in this particular area here. Would it be agree? Yeah, okay. So when we're looking at this particular structure, this structure can be due to different things, right? So obviously we have your bone, okay, osseous around this bone edema area here. This area here, you have a layer 1 bone, you have your cartilage, soft cartilage, and also the patellar femoral joint surface on the under edge of it, usually get triggered in the first 30-degree eccentric loading going down the staircase, right? And then you mentioned that you think it's at the layer 2. So obviously we have our meniscoid structure, we have your synovial capsule, but if it's a synovial capsule, you will have a horseshoe type swelling around this particular area here. And then you have fibrous capsule, and the ligaments that you're probably talking about is the retinaculum that runs over the edge of this. So for the fibrous capsule, when you go into end range flexion and extension, there is a restriction of loss in both ranges. Synovial capsule, we just mentioned, there is a horseshoe type swelling on the top of it. In fact, people are now working towards, rather than measuring the above the patella, people are now measuring just using a patellar tap test, left versus right, as a comparison. If I'm looking at retinaculum, usually I'll be looking at this particular area or this particular area here. Okay, so in a knee extended position, we will then look at into going down this area and push and prod around this area here. Bearing in mind, I'm not pushing onto the fat pad structures around here, and I'm also pushing up towards this particular area here with the intention of seeing this particular retinaculum tightness or not. Okay, I probably would be focused less on the VMO as such with the insertional type structures, but you do have some points. Okay, so yes, with the VM, with its primary insertion on this particular area here, if I were to give it a bit of a landmark type stuff, that is the insertion of VM right here. Okay, because of this particular insertion of VM, they tend to cause a bit of a quadricep tendinopathy rather than a referring down to this area here. That's more likely than not. Okay, another structural stuff that you could be thinking of is the usual stuff whereby when the hip internal rotation is reduced, therefore somewhere here is having to compensate by having a little bit more internal rotation. As a result, when the knee is bent, there is a little bit more stretch through this structure, therefore they are painful. How would I know that difference? Will be when I test for the ligamentous stiffness around this particular retinaculum. You will find that the ligament is basically just swollen rather than stiff or tight. Okay, and the story would meet when you tell me post-treatment feels good, so you sort of relieve the pain out of it, but progressively, because of habitual movements and all that, it starts to refer into the area, right? So the hip may need a little bit of focus, tibia may need a little bit of focus in terms of how it moves, and another classical thing that refers to knee pain right here, or maybe a bit vague around this particular area here, it's a structure that Rajesh focused a bit on as well, is your popliteus. It runs from here, finishes somewhere here at the back here. It is a weak internal rotator. It is a primary stabilizer. With any knee conditions at all, it's almost certain that we know that this popliteus has been shown to be 300 times its activation, and it's held in an actively guarded position. So it's like our suboccipital that doesn't know how to let go. Therefore, our upper traps and all that will get a bit stiffer and tighter and so forth. So lots of cars thing to address this particular structure. The final structure that you need to look out for is this essentially is layer 1 to 4 presentation. The final structures that you need to look out for is one of my patients that I had was a release around the particular tendons here, irritate on the skin level. The skin nerves of the patella, inferior patella, comes from the saphenous branch that runs up this way. Okay, it goes medially this way. Okay, so that means you need to trace all the way up into sartorius, and somewhere around here has its irritation, or it merges with the femoral branch somewhere around this area here, and then it will have its referral down there. So that femoral branch merging may means that this particular quadricep over tonicity can increase tonicity over it. So have you look at prawn knee bend, right? Okay, so in terms of going back to the structure you're still treating it, so say assuming that what you are saying is absolutely correct and all that, then we're gonna look at just purely the retinaculum. How are we gonna condition out a retinaculum to provide, say it's a stiff, tight, Rajesh didn't release it, Rajesh released surrounding of it. It means you need to do nailing and eccentric to lengthen, stretch out this particular area. You need to do Peterson's step down, so eccentrically lengthening out this part again. Knee over toes type work. See what works best for this particular lady. But it's not a high repetitive load, because if you just keep moving, this particular structure is not going to get any form of stretch. You need at least a 5-second concentric, eccentric, isometric type thing on through it. Then you create a stretch on that structure.